The changes that are going to be happening in the next 3, 5, 10 years are going to be hugely dramatic. Think in terms of a clinical trial now that's set within a certain disease state, and now you're able to run generative AI off of the data that's coming in from that clinical trial. There's applications obviously now with the Apple Watch and the Samsung Watch, et cetera, where you've got the ability to get real-time data off of these types of devices and then do analytics off of it in real time. And so, having that ability to be able to capture that information, run generative AI to say, okay, you've got this heart kind of issue going on. You may want to go see a doctor, or you've got maybe this oxygen component going on. You may want to go see a doctor. And so those are the kind of things that I see as being kind of worldly changes in healthcare going forward, getting kind of the data concept on how impactful your genetics and the treatment protocols will be in the next 3 to 5 years are going to be dramatically changed because of the information that's coming in.
This episode of Ken's Nearest Neighbors is powered by Z by HP, HP's high compute, workstation grade line of products and solutions. Today, I had the pleasure of interviewing Eric Doherty. So Eric is a global executive leader in the healthcare and well-being space. So he's focused more recently on how AI is integrating with the space, but historically he's worked and held over 5 senior executive leadership positions in pharmacy as well as medical devices. In this episode, we talk specifically on the transformation of the healthcare space as it's related to data, as well as what the future might hold for that same space with new technologies like generative AI and some of the data challenges that come along with that. I really enjoyed this interview, and I hope you will as well. Eric, welcome to the Ken's Nearest Neighbors podcast. Thank you so much for coming on.
Hey, Ken, thank you very much. It's been a pleasure getting to know you and watching your golf game when we played about a month ago.
Yeah, so for those that don't know, if you saw my more recent SAS Championship video, I got to play with Eric in that foursome, and we had a really good time playing with Bernard Langer, but we also got to doing a little bit of talking about data and healthcare, and that made a perfect opportunity for us to have this little conversation here.
Perfect. Yeah, I agree. And I will say Bernard was a pretty darn good golfer, even at age 66. He's a pretty awesome player.
Awesome player. Honestly, I thought he was a even better guy. He took the time with us. He was willing to coach us through some things, was willing to have serious conversations and answer the questions that I had, which were plentiful.
Exactly. And I still like that one shot you had. It was a par 4 over the trees. That was impressive.
Exactly. Yeah, that was. I wish we got more of that on video, but at the end of the day, we're limited by resources. But Eric, just to help introduce you to any of the listeners here, it always helps to hear a bit of an origin story. So I'm interested, first, if you could tell us where you got exposure to healthcare, where you decided that might be something you're interested in pursuing, and also where that interest in healthcare intersected with data eventually.
Yeah, great question. And, early on, I think I mentioned to you when we got together back in October, my dad was a pharmacist. So I literally grew up in healthcare. He was on the Walgreens side and basically was running businesses in Illinois for a number of years within the Walgreens Corporation. And through that, obviously got the ins and outs of the kind of healthcare industry, seeing it from his viewpoint at an early age. But I think where it really made an impact for me was when he actually had his first heart attack. I'd been in and out of the ER a couple of times with, minor little scrapes and bumps. But that was really the first time that I had actually been kind of at the forefront of seeing, what is being done in healthcare, at a hospital level. And this was back in the 80s. And so, the EKGs were still being run, the pulse oxes and things of that nature were just starting to come to fruition. But the need for data and the need for data to treat was evident back then. And then obviously, if you throw in analytics, that's obviously going to be more beneficial for a patient like my dad. And so through the years and through kind of my focus on what I wanted to do in healthcare, which is really what I really strive towards, started at an early age and through the different roles and education that I pursued, throughout the last probably 30 plus years of my career, it just really, focused on obviously the business side of healthcare, but also on the data side of healthcare. And that was really kind of both at the business level of data analytics on business numbers per se, but also on the health side and looking at what type of data can come out of an electronic health record system or different types of devices. And so from that, then it's just to build kind of a career pathway based on that.
Amazing. And what drew you to the business side rather than maybe the more specific practitioner side? I mean, you'd mentioned your dad was a pharmacist. He obviously did work at Walgreens, I believe in corporate, as you'd mentioned. Both my parents were doctors, and it was pretty clear to me that a practitioner, it was not the route that I personally wanted to take. I'm wondering how you divvied that up in your mind.
Yeah, it was 18 years more, or 12 years more of school when I was in high school. And that was a lot. And for me, I had the passion, but not the drive to do another 12 or 18 years of school. Now, ironically, I kind of did it anyhow with the MBAs and other stuff I've done. But I think a lot of that was also kind of the pathway of the schooling that I did do. I did go to the College of Pharmacy where my dad had gone and tried that. I worked in a pharmacy in a hospital, in a basement of a hospital. And really right there and then I knew that that was not going to be the pathway for me. And so jumped out of that, pretty much ran through the rest of my schooling that was really focused on business. And I think that's what, kind of led me to where I'm at today, where, getting all of the different, educational pathways, but then the business pathways in pharmaceutical medical device companies has just led me to kind of keep on that same business direction.
Something I've realized over time is that it's not a great return on investment to go into, for example, pharmacy or medicine if your main goal is to make the largest impact possible. As you mentioned, you have to go through 18 more years of school in order to be able to start, you treat some patients and stuff in residency and those types of things, but to have the real impact that you'd like as a doctor, it takes a lot of time.
Yep.
On the other hand, as a business person, your first year out of school, or as a data scientist or an analyst or whatever, your first year out of school, you can be making decisions or helping improve decisions that can save lives right out of the gate.
Exactly.
And if you compound that over the 8-10 years that it would take to actually become a doctor or a pharmacist, then you get these massive returns. I saw a very interesting research about someone essentially going to trade school and becoming a plumber versus becoming a doctor or becoming one of these other high, high prestige professions. And the compounding of the income that you make in those early years actually makes up for almost all the difference that you would make over the course of your lifetime being a doctor or some of these other professions. To me, that was kind of mind-blowing, is that, yes, it's not about necessarily, I would imagine most doctors care a lot more about making an impact or creating value than other people doing other professions. But if you're looking at it from a pure financial business perspective, there's the two avenues. One, you can make more money doing something else. And two, you can essentially, or can in theory, make more business impact or value or life impact over the course of a career in another profession. And that was a massive light bulb moment for me.
Yeah, I fully agree. And I think that was where it was pretty impactful too. Because, where I was initially was with Glaxo Inc. And, launching many, many medications and working with a number of medications in different roles within that company, the impact was pretty succinct and pretty rapid. Just because if you've got a new product that's in a disease state that covers a certain patient type of profile, and you can, help that patient alleviate that disease or minimize that disease, that's impactful. I mean, you're making their lives better. And so for me, that was, definitely a draw to the industry, and to be able to make that impact quickly was definitely a need and definitely a passion of mine.
So this is something I have no exposure to. What does it take to launch a medication? What does that process look like? To me, that is so foreign to alien. I think we probably heard a lot about it more recently with vaccines and things like that, but I don't really know what the whole process is like. And I would imagine data is integrated into that process in some sense as well.
Yeah, I mean, I think first and foremost, you have to figure out, again, what disease state you're going to go for. So that's kind of the first kind of checkpoint. And then from that, then it's really trying to find a drug that would work to combat that disease. A great example would be, let's say, going back to your vaccine kind of theory or even a flu theory. once you kind of nail that down, find out a medication that works, and then start doing the clinical trial work around that. And that's really, again, drug discovery. That's kind of that part, which is kind of a phase one element. And then you go into a phase two, which is animal trials. And you go to phase three, which is human trials. And then even a phase four after approval, where you actually see how the drug is performing under an FDA approved type of scenario. That time frame can be anywhere between 5 to 10 years. That's why a lot of times where drug patent, drug company goes and files a patent for a medication, they might get an 18-year or 22-year type of patent life. And that's why they're speeding through as fast as they can to get that product through the clinical trials, through approval, and then out in the marketplace to where they can actually get a product on the commercial kind of pathway and start getting money back from all the money that they've spent. I mean, typically for a pharma drug, it might cost anywhere between $1 to $1.5 billion. It might be even more nowadays, to get through a clinical trial kind of scenario and approval. And obviously that's money that they need to recoup and recoup fast. And so if it's not an approved product in a short period of time and it's running out of patent life, that's a big problem. And so then it also becomes, from a drug standpoint and company standpoint, do you go down a certain disease state? If a drug pathway is going to be too difficult to get an FDA approved medication, you may look for a different type of drug disease where it might be easier. Maybe something in dermatology, maybe something in a topical form or a nasal form. So that's some thoughts that you have to go through as well to see, okay, what time frame, what cost, and then what outcome can you get within that kind of setting.
So it seems like if something... Tell me how this scenario would play out. So we have a drug that's proposed. It does not meet the criteria to be successful for a certain disease condition, but that could be useful for something else. We just don't know it. Does that just go in the discarded pile and we don't revisit it unless someone's really creative and willing to take risks on that? Or what does that look like? I mean, to me, there's two sides to it where, hey, we have a lot of these compounds that we've experimented with that might have some impact on these other things, but we haven't looked at them. Or we're looking at this end state and we're trying to find something that specifically matches that. Is there exploration in both directions, or it's mainly, hey, this is the goal, we're going to try a bunch of stuff to meet that goal. If we don't meet it, we just sort of toss it out?
Yeah, I think it really depends on the company, because as you probably remember, if you remember Proscar, I think it was the name of the drug. It was a prostate cancer medication. I think it was prostate medication, and to alleviate kind of the benign prostate. And that drug worked very well, but they also found out that it grew hair, propecia. That's kind of the element that happens where you've got a drug that, is for one category, but they find out it works for another. So that's a great commercial kind of advantage. Where it comes into play, where you've got a medication that maybe may fail within a certain disease state. A lot of times these pharma companies will put it on the back shelf. They may revisit it. They may sell that off to another organization. They may repurpose it. So going back to, like the prostate cancer part, they may find that, over a period of time, there may be other elements that they can kind of, I would say, twist or retwist the medicational components of that drug to fit into a different disease state. But again, that takes time, it takes money, it takes effort. And it's a question of whether or not that pharmaceutical company want to take that route or not.
Yeah, pharmaceutical is very interesting because it seems like a series of very large bets that take a long time to pay off. And it's, that makes data very interesting in that space in particular, but it also makes it, a little concerning from the sense that you have essentially large organizations being the only people who have the financial stability to be able to take those bets. I mean, there's some smaller ones, but it's interesting to see how that plays out in a marketplace.
Yeah, I mean, and again, a lot of the negativity that comes around the pharmaceutical industry is, that they're making all of these gobs of money. Well, the problem is, and unfortunately, they probably don't market it as well as they should, is the amount of cost that is put into trying to bring these drugs to market. And really, for every one product or maybe two that's making, a good amount of money, $1 billion, $2 billion, et cetera, that's out in the marketplace, they've probably spent well over 15, 20, 25 for these other 10 or 15 medications that they've tried to bring to market and didn't have the opportunity to do so because it failed, or maybe there were some pretty massive side effects, or just wasn't a drug that worked for that certain disease state. So that's where I think there's some misconception on where the value lies within these pharmaceutical companies. I do think and believe that from a value prop standpoint, they're the ones that are putting kind of their money on the line, literally and figuratively, and to be able to do that and to push the envelope to get a either a rare disease type of medication or a widespread medication, let's say for either diabetes or other major condition. That is a lot of money that they have to put on the table to bring to market, and they're willing to kind of toe the line and do that. And so if that's the case, then they should reap the rewards at the end. My personal opinion.
Completely agree. I think one of the challenges that I see is that you do have some of these rare disease conditions, some of these things that affect smaller portions of the population, and financially it just doesn't make sense to be able to support some of those in the long run. But that is essentially the cost of doing business. Like it's a supply and demand type of equation for a lot of those things. And it's interesting. Obviously, there's government subsidies, if I remember correctly, and things along those lines. But how do these companies interface, for example, with the government, right? Where there's it's like hey, here's a goal. We have an obesity endemic in the U.S. Are there incentive structures set up along that, or is it all purely profit motivated based on the consumer side of things?
Yeah, I mean, on the initial part of it, NIH and CDC and even HHS, they do have a number of potential applications where you can look at certain either disease states that they're very interested in. Oncology is another big one from a disease state standpoint. So there's obviously a number of different oncology diseases, but where government fits in is that they will help more at the research level, but not really at the true clinical level. Where it comes into the phase 2, phase 3 clinical trial elements of it, that's where the burden really lies back on the pharmaceutical companies and medical device companies, depending upon the structure, to bring that to market. More on the short term, proof of concept and that type of realm at the beginning at a phase 1 level is where the government helps out, and it's typically substantial. It could be in the millions, but when you're talking then to go to a phase 2, phase 3, then you're talking millions, if not $1 billion, as I mentioned before, that it may cost to bring a product to market.
Let's take a second to hear from one of our amazing sponsors that supports the show. Ever wonder how to keep your AI models not just smart, but responsible and effective? That's why I've partnered with Aporia. Their AI performance platform offers full-scale observability and real-time AI guardrails. Trust me, if you're in the data science field, Aporia's got your back. Don't miss out. Check them out at aporia.com. This episode of Ken's Nearest Neighbors is brought to you by Z by HP, HP's high compute, workstation-grade line of products and solutions. Z is specifically made for high-performance data science solutions, and I personally use the ZBook Studio and the Z8 workstation. I really love that the Z workstations can come standard with Linux or WSL2, and they can be configured with the Data Science Software Stack Manager. With the Software Stack Manager, you can get right to the work of doing data science on day one without the overhead of having to completely reconfigure your new machine. Now back to our show. Amazing. So you'd mentioned this is where you started your career. How did you get to where you are now? What are you working on in this current iteration?
Yeah, now it's the intersection of healthcare and data. Obviously now with the aspects of generative AI, becoming really hitting the forefront of healthcare. The changes that are going to be happening in the next 3, 5, 10 years are going to be hugely dramatic. You mentioned the clinical trial side with pharmaceutical companies. Think in terms of a clinical trial now that's set within a certain disease state, and now you're able to run generative AI off of the data that's coming in from that clinical trial. The aspects of finding out, okay, is this medication working or not genetically, pulling in that type of data for a patient profile in a clinical trial. Is that patient the type of patient that should be on that medication, et cetera? So all of that's going to be at the forefront of kind of the future of healthcare that I see. And then I also look at kind of I would say the wearable side of things and the monitor side of things. There's applications obviously now with the Apple Watch and the Samsung Watch, et cetera, where you got the ability to get real-time data off of these types of devices and then do analytics off of it in real time. And so, having that ability to be able to capture that information, run generative AI to say, okay, you've got this heart kind of issue going on. You may want to go see a doctor, or you've got maybe this oxygen component going on. You may want to go see a doctor. And so those are the kind of things that I see as being kind of worldly changes in healthcare going forward. And then I think as well, just the aspect of, getting kind of the data concept on how impactful your genetics and the treatment protocols will be in the next 3 to 5 years are going to be dramatically changed because of the information that's coming in.
So going from, for example, when your dad was in the hospital in the 80s to now, you're seeing all this data. What are the biggest changes related to data, and what are some of the limitations of that, some of the bottlenecks, some of the greatest opportunities? I know, for example, HIPAA makes health data very difficult to transfer around for us to see the whole picture, but at the same time, it creates these really good privacies for ourselves and protects us in some sense. Even beyond that, what does the ecosystem look like over time?
Yeah, I'm going to go back to the 80s to now. Unfortunately, not a lot has changed. I think what we're finding is that there's still issues with what to do with the information, what to do with the data. I think there are better ways of treating. There are better protocols in treatment, but I think that there hasn't been a huge change in improving that person who, in the 80s, had a heart attack compared to in the 2023, 2024 standpoint, having a heart attack. There's not much difference, unfortunately. You've got maybe some benefits of, surgery, inpatient surgery to open up some arteries, that type of thing. But outside of that, not a lot. And what I see is still a number of, what I call silos of medical information, where you've got maybe a hospital that has their information. They don't want to share it with other hospitals. You take a Mayo, or you take a Cleveland Clinic, or even here in Atlanta, you take a Piedmont or an Emory. Those institutions don't talk amongst themselves. They see their patients. If that patient goes from Emory to Mayo, or Mayo to Emory, or Cleveland Clinic to Piedmont, they do not talk, and they don't know what happens with that patient. And so that's also, I think, a big burden to the healthcare industry, in that that patient information is not, quote unquote, shared or shareable. I do believe that the de-identification of data, de-identified data, anonymized data, is the way to kind of go through that pathway and to allow data to be moved more succinctly. You still have to worry about HIPAA, but not as close, because obviously you're not getting the quote unquote patient record. But that would be, kind of an element of concern that I still have, that's been around for decades, unfortunately.
Yeah, I mean, it seems, from outside looking in, I got an MRI on my shoulder a little while ago, and they're using a machine from 10, 15 years ago, which is fine. I mean, the technology still is good. It still serves a purpose, but it seems like medicine, because it works and they're focused very, very intently on short-term improvements. So, hey, he comes in, how do we fix what's wrong with him currently? That we're stuck in this loop, very similar to what big businesses get into when they're stuck in quarterly deliverable cycles, or quarterly earning cycles, where, hey, we just have to keep our head afloat. We have to hit this quarter's earning, this quarter's earning, this quarter's earning, and we don't think about how this completely transforms the future. And you get into this space. So I think healthcare has some startups, but not quite as many. But with startups, they're not worried about the quarterly targets. They're worried about executing this long-term vision. And that really helps you if you want to innovate or you want to create a difference in a space. But I think medicine, unfortunately, it has a lot of red tape, and it makes that innovation very difficult to come by. I mean, what is maybe there isn't a simple solution, but what is the solution of cutting through a lot of this red tape to be able to have true analytic innovation in the healthcare space?
Yeah, I do believe that anonymization, de-identification is one key pathway, because I think that's where, keeping the data in house is beneficial to a healthcare community, to a healthcare network, and sharing that is not something that they are privy to doing, unfortunately. But if you're able to, show the value of, hey, anonymized data is the way to go. Anonymized data is the way to do research. Anonymized data is the way to improve health and be proactive on that information through the kind of system integration of moving from, the siloed type of structure into more of an open format. That helps not only the system, because you would still have access to all of the data, but also access, to the patient itself's data that would be moving from one network to another, and allow that information to be provided back to them that they wouldn't have had previously.
So does that take a third party doing that, I would assume? It seems to me like the hospital or medical infrastructure is not suited to do that on its own.
Yeah, typically you'll use outside resourcing for that. There's groups that actually take the data, they'd pull it out of an EHR system, be it an Epic or Oracle Cerner, et cetera, and they'd be able to de-identify, anonymize that data, and then move that data through to run it in for analytics. So that ability is currently available, which is great. Where again, the unfortunate aspect of it is that the major health networks, they're not accessing the data that would be going to another network if that patient went to that other network. So that's where they lose out, and the ability to kind of trace and track that patient throughout that healthcare kind of continuum is where they're losing out from not only a following standpoint in health records, but also a research aspect for not only that patient, but others that leave their health network.
So from that research aspect, something that I've been noticing quite a lot as a shift in the overall view of health has been this change from sort of immediate care, or what I would call Band-Aid care, to preventative care, which seems like what we should have been doing all along. Everyone saves more money if they take better care of themselves, and they
Right.
don't have to go to the hospital as much. But there's definitely some bottlenecks to that. It's just not how medicine operates to begin with. And I'm wondering what processes have to go into changing that culture within medicine, or is that something that, it maybe is a bigger problem than data itself, is we have to change how medicine is done overall.
Well, that's actually kind of what needs to be done. My thought is it's accessibility, and as we saw through COVID, the accessibility ramped up quite quickly because people couldn't go into the hospital. People couldn't go see the doctors because obviously they were mandated against either going into those institutions, or they avoided those institutions. So the ability to pull in telehealth obviously ramped up. The ability to do remote type of monitoring increased. And so all of that kind of lent itself then to move forward into the aspect of kind of that preventative capability of telehealth services, remote patient monitoring services, et cetera, that would be, again, a great pathway for seeing those patients. And what I also think is kind of a key element is the fact that, patients like to be on top of their medical records now. I think that was something that years ago they never really kind of thought of. They thought their doctor that they saw back in the 80s or even in the 90s, they'd see the doctor, and if they felt bad, they'd go back. Now it's more, I think, with the younger kind of generation and the kind of aspect of instantaneous data, the ability to kind of keep and hold on to your records and know what they look like, your MRI, as you mentioned, with your shoulder, that kind of information is something that you can keep with you and kind of hold to make sure that your shoulder's not getting worse, or that your GI issue is not getting worse, et cetera. And so because of that, I think that just lends itself to hopefully getting patients better and having better outcomes going forward.
So something I've noticed, maybe it's just in my peer group or things along those lines, is there's significantly less trust in medicine than I think we used to have, especially my parents' generation. Again, both my parents are doctors. They have complete ultimate faith in medicine. If my parent has a little pain in their shoulder, they take something. If they have a stomachache, they take something. And I think that maybe millennials, Gen Zs, whoever it is, are less inclined to medicate when, or maybe that's a subsection of that population as well. But yeah, how do you build trust within these communities with data when data can be interpreted in so many different ways? Probably a very difficult question to answer, but I figured I'd put you on the spot a little bit.
Yeah, no, I like it. I like it. And that is probably very, very true. I think a lot of the energies that are moving forward are in the holistic treatment protocols, the dietary supplements and things of that nature. And a lot of folks are trying those before they try a medication. And as we've also seen, a lot of these medications could potentially be tainted. So there's that kind of complex issue that's going on too. If you've got a medication that's made, let's say in China, is it being made right? Does it potentially have some other products in it, and that might be obviously detrimental to a patient's health, especially if it's a very life-changing type of disease. So that is kind of the pathway, I think, of things that have been happening over the last couple of years. On the data side, I think it really revolves around showing that the medications work, that the medications work well, and then the medications work safely. So if there's ways that data can be run and shown either through, again, that would be more of a phase 4 type clinical trial post approval, those types of elements of data analysis and providing information back, it would be hugely valuable. And it would be something where, even from a payer system, would be hugely valuable, where you've got an insurance company that's covering patients and with certain disease states. If they can see a medication works better than another, that is more safe than another, that's of huge value in the long run. And so that safety part would be definitely be able to be shown through data analysis.
I completely agree. I think there's another angle as well where, for better or for worse, hospitals, doctors, they have a lot of patients. They're seeing a lot of churn, and most individuals that come in are treated almost as a commodity where, hey, we're checking these specific things. You're not looked at necessarily as an individual. And I think as we go forward, one of the big steps in medicine is going to be more personalized care. For example, there's all these blood tests you can take. There's one called Inside Tracker. There's one through Merrick Health where they do all your blood work. They track it over time. And, I go into my doctors and they have very few data points on me. They might see that I have high blood pressure, but maybe I was, I forget what the trait is called, where you're just nervous to be at the doctor or something along those lines, and your blood pressure goes up. But there's all these things where there isn't longitudinal data on patients for the most part, and we're also not measuring that longitudinal data against a benchmark of age or of risk factors. I mean, me being East Asian or part East Asian, I have a lot higher instance of diabetes. Just out of the box with, looking at my hemoglobin A1C might be a lot more relevant than some other people.
Right.
And to me, that's something that I think technology maybe might be able to have the largest boost to, is creating that story for ourselves, just like you were describing, ownership of that personal data. Can you expand a little bit more on that?
Yeah, I mean, I think that's very, very spot on. Again, when you take into account, blood testing, take into account genetic testing, take into account, wearable information that you got from your Apple Watch or Samsung Watch, et cetera. That information is very telling. And I think, again, because of the fact that if you're doing, testing over a period of time, or you've got obviously the wearable information coming in over a period of time, that's data. And if you can run analytics off of it, if it's both machine AI or generative AI, and more importantly nowadays, generative AI, that's going to be a huge win-win for a patient's health over a period of time. And totally agree with that. That's, I think that's kind of, again, where that 3, 5, 10 years, from now, it's going to be commonplace for somebody to go in, get a genetic test. This drug works for your demographic with your kind of, body set, et cetera. This drug doesn't work. And so because of the information that we'll get over the next couple of years, that is going to be the way things are going to be diagnosed and then obviously treated.
Yeah, I mean, it's funny. Even simple things have massive genetic variation. I was watching a video, I was reading some research. I went down a really weird YouTube rabbit hole, but it was about essentially salt or sodium impact on blood pressure.
Oh,
In
yeah.
all of the studies, there's people who are like strong responders to salt and blood pressure and low responders. But as a baseline, it's better for people not to eat as much salt if they have high blood pressure.
Right.
But it really is very dependent on their genetic makeup. But it's a lot easier and probably better overall for um, a population to just limit salt rather than figure out if they're individually a high responder or a low responder. And so even little things like that, it's like, hey, maybe I can enjoy that salted butter on my fresh made sourdough bread, when, and it doesn't affect me like it might affect someone else. And I think
Yeah,
that like that little nuance, it adds really to quality of life.
agreed.
Um,
Well, and even if you go back to like a lipid panel, if you've got a patient who takes a lipid panel over a period of time, is the medication that they're taking, is it working? If you do scanning, et cetera, over a period of time, that data all put together, maybe over a 2, 3, 4 year period of time, can literally show that picture of whether or not X drug or X statin or whatever they're taking is working for that patient or not, and then obviously make those changes. And then you throw in the genetic part of it as well as we go forward to really see, okay, is that statin better than that statin? That's going to be where we'll be in the next 3 to 5 years.
I hope so. I mean, because you think about it, you're like, oh, we're trying to lower our blood pressure. We're trying to do these things, and you're taking a medication from the doctor, let's say a beta blocker, and you go in and you have one shot or one data point of if this is working or not. I mean,
Yeah,
most doctors aren't saying check this every day, measure it, like keep tabs of this over time. That to me is inherently a problem. Anything could happen that day where you forget, you drink an extra energy drink or something, and it spikes things. And oh, this drug that we prescribed you isn't working because of that one data point. To me, that is fundamentally flawed in the approach, and that's also where the wearables you were describing could help. Um, what we're describing here are very much these first world problems where we're working in the realm of good resources and have access to a lot of these technologies. I know a lot of your work is related to kind of the opposite of that, where people have limited resources and how analytics can be valuable there. Can you talk to me a little bit about what that playing field is like and what types of solutions you're coming to?
yeah, that's a huge issue, as we all know. I mean, we're blessed. I mean, we've got a very good healthcare infrastructure here in the United States. We've got great doctors, great payer systems for the most part, and just the ability to walk into a hospital, whether you can afford it or not, they'll take care of you. Where things really drop is really in those countries that are kind of in that third world type of area where they're underdeveloped. They don't have the infrastructure, they don't have the hospitals, the doctors, et cetera. And so the aspect of getting healthcare into those areas of the globe is obviously going to be and is essential. People die every day, unfortunately, from a lot of medical conditions in these lower to middle income countries where we've never even had an issue here in the United States. I mean, malaria, as an example, people are dying every day from malaria, not in the U.S. or in Europe or in these developed countries. So that is something where the need for not only just basics in healthcare, but then obviously the analytics in healthcare is desperately needed. And I think that's also the flip side of it. You've got the benefit now of patients in underdeveloped countries. And so looking back at the pharmaceutical business and the pharmaceutical industry, particularly, the ability to go into a certain area of the globe where you've got patients or people who are basically medical or medication naive, where they've never been on a certain medication, they are the perfect candidates for clinical trials. So, as kind of the structure of pharmaceutical and pharmaceutical clinical trials is expanded, the ability to move into those underserved communities, not only help them with health, but also potentially help them with clinical trials, is of huge value, not only to those pharmaceutical companies, but really just in population health in general, because you've now got the ability to trace and track patients through clinical trials on medications that they've never been on or even close to, and really see the value of how certain drugs work with those types of patients and probably develop even better drugs because of it.
So, is there a downside to that? For example, someone in Africa that has a very different digestive system in terms of like gut microbiome and those types of things, and very different experience that maybe they're deficient in a vitamin that we have that, let's say like iron, that I'm probably
Mhm.
plentiful in based on how much steak that I eat. Are there implications that, hey, this sample is not necessarily realistic for the broader sample of a drug like this, or are there ways that they can get around an issue like that?
Yeah, I mean, there's definitely ways to get around it. If you add in a nutrition component and a dietary component, yeah, you could get around that. I think where I'm thinking through it is more along the lines of if you've got a patient who's never been on a statin and you want to do a cardiac type of clinical trial, or you've got a patient who is a potential diabetic and they've never used a diabetes medication. Those are probably the best patients to try a diabetes drug on just to see, how well it works. And then again, you could throw in the dietary component if need be, and that would actually be a benefit to that person as well. Obviously, if they're fed better, et cetera, over a period of time, that would be of value. But that's kind of where I come at it is really more because of the naivety of that patient in element, and then running a clinical trial based on whatever disease state because they haven't been on that medication, I think would be hugely valuable. Because right now it's not really being done here in the United States as much as it should.
That makes a ton of sense. So you'd mentioned generative AI a couple times. What phases of healthcare is generative AI most going to impact? So I would imagine drug discovery is probably a big one.
Yep.
I'd love for you to talk on that and any of the other areas that you see it being able to make a massive difference.
Yeah, appreciate that. You definitely, yes, drug discovery. And I would even add potentially moving phase 2 clinical trials, which are the animal clinical trials, out the door where animal clinical trials may not be needed. Because if you can run generative AI on data and show that it would work just as well as it would in an animal clinical trial, that's a huge value benefit. I think you'll always have the benefit of having or the need to have a clinical trial run in a human patient, just because obviously you want to make sure it works. But the element of removing or reducing the amount of animal trials, I think, is something in kind of the way that things are leaning forward towards currently. I would say in the next probably 3 to 5 years, that'll be pretty much phased out. Other areas of healthcare, I mean, obviously anything that has to do with, monitoring any type of genetics, all of that's going to be, I think, short-term change. I mean, I think like I said, I would say 2-3 years, we're going to find so many new nuances coming out of the data and the analysis of that information that is going to be a game changer in that generative AI space. I mean, machine learning AI has been around for a while, but I think now that the generative AI is being pushed and being run, to take information that is there, make it better, make it better, make it better, that's going to be very, very telling in a very short period of time.
Amazing. And so, with all this data analysis, with this change coming up, what do you think the single biggest thing that like we as individuals have to do to prepare, or even organizations should be doing to prepare ourselves for any impending change in medicine? Like, is there anything we have to do, or should we just let it happen? Or is there any way that we can help, essentially push this along so we get, better care, better data quicker?
I think first and foremost is really trying to make sure that you know what data that you are providing and where it's going. Right now, again, as I mentioned with the Apple Watches and the Samsung Watches of the world, there's data out there that people are providing. Where's the data going? How is it being handled? Is your data private? Is your data anonymized or de-identified? You've got to start thinking through that and seeing if it is and or not. And if it's not, then try to do something about it. Where I think also kind of the pathway of the future is going is more along the lines of, again, hopefully, that unsiloed approach of data. So the movement of data from system to system and the ability to trace and track that data from system to system. I think that will be very, very beneficial to not only the patient, but also to the data analysis people, because then they'll have more open access to that data. And then last but not least, I think it's more just ensuring that we don't end up going towards the Skynet type of the world, Terminator 2. Sorry, guys. I might be dating myself, but Skynet was the kind of the internet ruler back in the Terminator 2 day movie. And hopefully from a data standpoint and generative AI standpoint, there are those fears of basically people losing their jobs, people losing their data, et cetera, in that kind of generative AI world. And again, if you take the data now, see where it's going, control your data, I think that's going to be a huge win-win going forward.
Amazing. Eric, those are all my questions. Do you have any final thoughts, any words of wisdom from people tuning in?
No, I think for those folks who are listening in, I think, one of the things that, I just like to say, if you're thinking about going into healthcare directly, please feel free to do so. If you're in a basement of a hospital and you have some thoughts, take those as an advantage and maybe go a different direction. If you're thinking about going into business and healthcare, go for that full throttle as well. I think the biggest and bottom line is make sure you've got a passion for what you want to do. I think that's always driven me, just having a passion to help others, a passion to do good, a passion to do more. And I think if you have that passion in whatever type of occupation, whatever type of kind of effort that you want to make, be it sports, be it business, be it whatever, if you have that passion, it'll drive you. And I think for me that, and for others, I think that's the way to go.
Amazing. A perfect way to end. Eric, is it all right if I put your links on LinkedIn and those places in the description? Yep. Perfect. So if you want to learn more about Eric, please go to those links in the description or in the show notes. Thank you again for coming on.